I'm June Gordon. I am emergency medicine and critical care at Stanford, and the APD for the critical care medicine fellowship.
Yes, and importantly was our chief resident when we did a project on return to work that you're going to hear all about during this talk. So, and I'm Mike Gisondi. I was former program director, now vice chair of education at Stanford, and it is our pleasure to be here. Thank you to Marianne and Dan for this lovely invitation to be able to speak today. Once again, it's going to be more us just sort of chatting, and I'm glad you guys attended. So the title of our talk is very important. It's Leave the Residents Alone and Let Them Be Parents. That was what I was trying to say when I wrote the title. The leave and the return to work. And they're very different things, but they should be considered in series so that we can really support our resident parents to be parents and to just leave them alone and let them enjoy their new family. So that's the goal of today. I have no disclosures, nor does June, but we do have an acknowledgement. We wrote a paper on the return to work policy at Stanford that you're going to hear about during our talk. And we certainly want to acknowledge all of the co-authors of that paper listed on the screen who are not with us today for their, thanking them for their contributions. So what are we going to talk about?
Now I get to go?
I don't know. Let's, yeah. Okay. What are we going to talk about?
Sounds good. We're going to talk about the leave and the return to work.
Yeah, okay. So we'll start with the leave. So we're going to talk about parental leave. What is it? Why does it matter? What are the rules? And how is it different for resident parents? And then we're going to talk about the return to work. What is it? Why does it matter? What are the rules? And how is it different from resident parents? So a very straightforward agenda, but hopefully we'll tell some stories along the way and make it interesting. I mean, it's parental leave. This is Daniel J. Egan gave me quite a topic here. So let's just dive into it. So what is parental leave? Parental leave is time off, protected, not necessarily paid, but time off to care for a new child. And this is really important. It's the care of children. It's not a medical leave from a complication of pregnancy. It's not bonding leave if you have a state that does bonding leave. It's to care for a new child in the immediate period after delivery. And there are a lot of different definitions of it out there, and our accrediting bodies certainly have their ways of describing it. I'll share just the ABMS and ABEM have their own versions, but I'll share the ACGME one since I think it's most relevant. So there are circumstances in which residents may be unable to work, and they list several, and then they include parental leave. They don't define parental leave or put any kind of parameters around it in terms of how many days, but each program must have an appropriate length of absence for residents who are unable to perform their patient care responsibilities. So what does this mean? When the site visitor comes, are they going to ask you how many weeks? No. Are they going to ask you, whether you have specific policies? No. But they're going to want to know how you handle absences. And if you need to have a policy for each one of these things, family emergencies and illnesses and parental leave, more power to you. But, I think ultimately they just want to know that you're able to include parental leave in what would otherwise seem like normal family emergencies. It's not an emergency, but it certainly needs to be addressed when it's interfering with work. So there's some institution-specific considerations that I think are really important. So when we're talking about parental leave, are we talking about maternity leave, paternity leave, or parental leave overall? And at institutions, they're going to define maternity leave and paternity leave in terms of how many weeks off or months off. They're going to probably determine them differently for mom and dad. So oftentimes maternity and paternity do not equal one another. And it tends to be the case probably at more university-based hospitals than not. Is there paid parental leave? So, as I said, this is not necessarily a paid protected time, it's just protected time. So your employer may choose to pay you for some portion of the time that you have allotted, but may not. And that's a big determinant for residents who try to figure out how long should they take. Whether they're being paid or not is very important. Is it available to new employees? So at some institutions, you have to have a minimum number of days worked before you're eligible for this benefit. And that's really quite critical for our new interns who come in and may have a child within the first couple of months of residency. You have to double check that your institution will allow them to have parental leave. If they don't, and you know about the pregnancy between the match and their start date, you may want to counsel them to extend their start date into the fall or early winter so that they're able to have appropriate amount of time with their new child and then starting work fresh. So it's not a guarantee, and it's certainly a really important issue for many interns. Is there a minimum length in weeks? So you can't just take a couple days here and a couple days there. There's usually some minimum, and usually in weeks. It's usually 2 to 4 week blocks, up to the 12 weeks that is standard. And you may or may not take it right away. So it's designed for care of a child in the immediate postpartum period. But if for whatever reason you wanted to come back to work right away, this benefit still exists at most institutions for a full year. So some residents may choose to take the benefit, a month or 2 months or several months later, so that they can have a specific set of months off to be able to care for their child. So it's not always, though most commonly it is in the immediate postpartum period. So what is it not? It's not pregnancy disability leave. So if there's a complication of the pregnancy, that is a medical leave. It's different than care for a child. So it follows medical leave policy. So generally 3 to 4 months, depending upon your state. And then it's not bonding leave. If your state has special time allotted for additional bonding, again, unpaid time, but time that can be protected, different than the immediate parental leave. All right, let's talk about why it matters.
So this is the easiest question of all, right? It matters a lot because this is important and this is the right thing to do and this is what we should do. But let's look at a couple of numbers. So 40% of trainees now plan to have children during training. We have an equal number of men and women entering medicine. We actually, for the first time a couple of years ago, had 51% women graduating. And the average age at medical school graduation is 28. And the average age of your first child is 26. So it doesn't take a genius to do the math to realize that this is going to become, if it isn't already, a real problem of time and weeks really soon.
Yeah, and especially for programs that really strive to have gender balance, this is a really big issue that's coming to term now. Did you see how I did that there?
That was great.
Oh, thanks. All right.
Very, very timely with what's being discussed.
Oh my gosh, so good, so good.
Okay.
All right, let's hear about a story when it went well.
So when did this go well? And so we talked about this, and this is actually a really hard answer, right? This went well because it went well for me. And why did it go well for me? Well, it went well for me because I had my first child my 4th year of medical school, which meant we didn't have to talk about leave from training at all, right? I came as an intern. She already existed. I had done all the things. And then I had my second between residency and fellowship. So I didn't have to take leave again. Instead, I pushed off the start date of my fellowship 6 months. I had an actual 6-month leave with my baby. We were pretty nervous that this wasn't going to go well. I was going to show up to critical care medicine fellowship 6 months late. People were going to
You were the only
out.
one that was nervous about this.
You were nervous too.
This was a really hard decision for you,
very
right?
hard decision.
Whether to start and take no leave whatsoever, or to just delay the start date. And I think this is an important moment to counsel our residents, should they want to do the same. So what made you decide to delay the start date? What were the final decisions?
I think you.
Yeah, I think it was me.
But I mean, honestly, this is a real conversation, right? I thought in a rational state of mind, said, I think I should take no leave. I think I should have this baby and go back 2 weeks later because that's the right thing to do. And I should start when I'm supposed to start. And I should finish fellowship when I'm supposed to finish fellowship because I'm a trainee and that's what I want to do. And I should. And it took a lot of people with a lot of this to be like, why? And it really totally was a mind shift. And it's so interesting to me now with the benefit of hindsight, because it was so wonderful and it went so well that I was so in that way of thinking that I couldn't even see out of it. And I think if we remember that with our trainees and we remember the pressure to return and the pressure to conform to the way training is intended to be, that it's pretty important to think about.
Yeah, I remember, I think conform is the right word. I remember our discussions very specifically being about the culture of medicine, right? So if you don't start on time, well, all of your other co-fellows now have to work a little bit harder while you're not there. Are they going to be upset when you started, et cetera, et cetera? And, play this out. And now, a couple of years after this decision, June is the assistant program director for the critical care program. So obviously it worked out. And it worked out both to the benefit of the program the benefit of her family.
I also remember so vividly apologizing to my then program director when I disclosed the pregnancy to him. I was like, I'm so sorry, I'm pregnant and I'm going to have this baby. And I'm really, really sorry because you're counting on me to show up and I might need to take leave and I'm not even sure. And maybe I can just come back and maybe I don't have to take any leave and it will be fine. And I recall very vividly him saying, "You're sorry? Like, congratulations, this is wonderful." And I think that was another turning point for me.
All right. So how about a time when it did not go well?
So I think this is always, right? The sad truth is that we had to come up with a time that it went well is for someone who went completely outside the system, right? It went well for me because I never actually took a leave. But every resident ever, it doesn't go well. And why is that? Because there's tremendous confusion about the rules. Mike and I wrote a paper on this. We're giving a talk on this. I read the rules again in preparation because I was so nervous someone was going to ask me a question. We discussed them and we're still confused, right? Because there are length of training requirements, they don't all agree with one another. There are suggestions and policies, and what's a suggestion and what's a policy and what do people have to do? There's a tremendous pressure to return, and there's a tremendous pressure not to make our co-residents and our co-fellows work harder than they otherwise would. And it's not the same for men and women, at least at our institution.
Absolutely not.
And what does that mean, right? Like, is this different? Is it not different? Should it be different and should it be the same? And what does that mean for parents? All right, so let's talk about California. The other thing we haven't even discussed, we're saying these rules are so confusing. They don't speak to one another. We don't even know what they mean. They're also totally state specific on top of everything else. So you'll take this with a grain of salt because this is our California example. So California has 12 weeks of FMLA, that's unpaid leave.
But then everybody has that,
Yes.
right? Yep, so that's a federal.
Oh, that's true, I lied.
Yep.
Thank you.
Then we have.
Then California has our Family Rights Act, which is our CFRA, which is 12 additional weeks of bonding, and not all states have that. They also have 4 months of pregnancy disability leave. But importantly, in California, you have to have 1,250 hours in the last year to be eligible for those things. So what Mike was talking about before, our interns are not eligible for this requirement. Interestingly, for me, in my fellowship, it was an ACGME fellowship in the same institution. So in my first year of fellowship, I would be eligible for leave, but if I was coming from another institution, I wouldn't be. And so those subtleties are also incredibly complicated. So now, what are these policies? What are these suggestions? What exists out there? So there's ABMS, and ABMS says people should have 6 weeks of maternity leave forgiven, and that shouldn't include all your vacation. So you have to not use 2 weeks of vacation. So that gets us to 44 weeks. ABEM says you have to have 44 training weeks a year. And then this begins this conflict of how do we get our residents the full benefit? Should they just extend training? Like, is there a way to get the full benefit without extending training? How do we maximize what's right for people and how do we stay inside the confines of these rules?
But I would say the answer to that question is no, right? If we're talking about 12 weeks of FMLA, there's no way to get 12 weeks and not extend training, right?
True
So it's
true story.
It's a decision. So here's our goals. We want to get to 12 weeks in this case example. Can we get there?
No.
No.
Let's see why.
All right,
Right.
tell us why.
All right, so ABEM says we have to have 44 weeks of training. So we're already stuck, right? Like, we can't get better than 8. So, okay, so our institution or this hypothetical institution gives you 4 weeks of maternity leave. Okay, well, that doesn't get us to 12. We have 4 weeks of vacation. We still don't get to 12. And also, this trainee has to use all their vacation time.
Well, it's terrible, right? They use all their vacation time when they might want to hold some of that vacation time for, the first year of life of their child. And then they don't get the full benefit, right? There's a federal law that says you can get up to 12 weeks. And in most cases, most residents don't have that option. So,
and I also think there's a reason we don't take our 4 weeks of vacation all at once, right? Because people need a break throughout the year.
Yeah. So let's stop there. I'm going to look at the chat really quick and see if there are any questions. Please feel free to just unmute and ask us a question too. So I see if delay in start date, medical insurance issues need to be taken into consideration. Absolutely, that's a great point, Marianne. Are there extension of benefits that a medical student can have? Are perhaps both parents are residents and there's going to be a benefit from the other partner. It was mentioned above, but were there any issues related to benefits insurance with a delay in starting your fellowship?
Great question. So I have the other thing that we didn't talk about in the case of how it went well for me is that I could afford to not be paid for 6 months, right? And because I had a husband who I could go on his insurance, and so I had no insurance issues, and it was no problem. Maybe not no problem, but it was okay to not have income for 6 months. And so not everyone has the luxury of that either. I will say, and maybe this is recorded and we shouldn't, but
that's the best kind of recording.
Our institution was willing to work with me and make sure that I had continuation of benefits throughout that time. So,
any other questions before we move from parental leave to return to work? Clear as mud? It's not clear as mud. It's really hard. That's why you're all listening to this webinar, right? The numbers never work.
The ABEM policy of the 8 weeks is inclusive of the 4 weeks of vacation, though. Isn't that correct?
Correct.
So it's still that. Yeah. Okay. I just want to be sure.
Yep, you have to burn all your vacation. Yeah. Which is terrible, right? Hopefully ABEM's listening. That's a terrible policy to have to burn your vacation.
One of the other things to realize is that the ABEM policy is relatively new, right? So
it is new.
This is not something that has been longstanding up till now. I think they may actually find as they go forward, there's going to be a bunch of challenges where that's not the best choice. And I think
it's
that
new and more
clearly,
generous.
sorry?
It's new and more generous than it was.
It is.
I think there was a little more flexibility before.
Fair.
Right. So there was definitely more flexibility. Although I think as a program director, one of the best advices is going to be to delay your graduation if it's mid residency and not at the very beginning and the very end, as you miraculously seem to time everything, June. And I think somehow letting the residents understand that it's not 10 years from now, nobody's going to ask you when you actually finish residency. It's just not going to be an issue.
Exactly. It's a cultural issue, right? It's this
Right.
idea that you must finish on time, and it's some sort of a badge of honor that you do so. Dr. Frisch has a really great point. So depending on and this is in the chat, depending on the flexibility of the leave, you could take it spread over multiple academic years. So crossing the summer, and then maybe get the full leave benefit without having to extend training. That's a ninja move. See,
we actually see this with our trainees, which is another reason that this is crazy, right? So if you have a baby right in between years, your leave is actually much better than if you have a baby in the middle of one training year, which is an unintentional consequence or optimization of the policy. But for sure, if you have really good timing, you can make that happen.
Right. And as Dr. Velez says, not many people can afford unpaid leave. That's true, certainly. But if they could, you'd like them to get the full benefit, right? And it's a shame that we can't do that. All right, so let's turn away from parental leave, which I think is very rules-based and certainly not fulfilling when we think about how little of the benefit our residents are able to actually engender. But let's instead talk about the return to work, which I think is a really, really wonderful time to support your new resident parents and to do so with great deliberate intentionality. So we're going to define return to work and provide it as a resource and a policy over the next several minutes. So
I think I think there's one question before we transition.
Oh, sorry.
I did actually, it occurred to me, traditionally we think of weeks of work and leave as weeks, and that's how our hospital approaches it too. But I didn't know if in emergency medicine, if anyone had tried to transition it to shifts to buy more time so that you could, has anyone tried to do this or had success with this where you say, like we can get you 7 days for 4 shifts and buy a longer period of time, considering that some of those days wouldn't be clinical work days?
That's a very interesting. Does anybody have experience with that? I certainly never did that.
I think one of the challenges also to realize as someone who was pregnant and had 2 kids is that in the process of trying to offload more time afterwards, giving extra time either ahead of time for the birth when the person is pregnant and maybe not at their physical most agile and comfortable, or afterwards when they have a brand new baby is also a challenge as well. The residents that I had when I was a program director, this came up and I advised them to extend the leave, and that worked into shifts. Or sorry, I advised them to extend their graduation,
Mhm.
and that worked into shifts that they owed at the end.
All right, so let's provide what I think is a really nice resource for you, and that's going to be a framing of this return to work period. So our resource has a couple of different parts and a couple of different intentions. One is to just get a shared understanding of all of the stuff we just told you between the program and the resident, because there's so much what if, and there's a lot of rules, and we have to look it up every single time we have a pregnant resident. So our document lays all of that out very well for residents. Then it has a set of rules that allow for a smooth transition back to work for new resident parents. And then importantly, summarizes all of our local and institutional resources that are available for new resident parents, both moms and dads. We have a lot, we're very lucky. There's a lot to be taken advantage of if you know that it's out there. And a lot of times residents just aren't clued in with many of the other employee benefits that other employees generally take advantage of, and we have to prompt them to be able to get all the benefits that are available. So let's talk about return to work when it went well.
So we had a resident who his wife had a preterm baby. She was in the NICU.
Mm-hmm.
He was still in the thick of training, and we were able to craft a return to work for him that allowed him, I think, both sanity for him and his partner, and to really optimize, visitation with baby. And so what we did is we had him work no nights initially after baby was born in the NICU. And what this meant is that they had another child at home, and he could be at home with their older child, and his wife could spend nights in the NICU. And this meant that she could actually visit her baby, which was huge. We also were able to group his shifts such that his in-laws and his parents were able to come in and out of town to care for the older child, and they could have a real rhythm to be able to visit their baby. And I think that the really wonderful thing about this story is this took a really stressful, really hard thing that happened during training, which is a really stressful and hard time, and really made it work for our trainee and for his partner and for their baby. And I think that was good.
And when we were piloting this return to work policy that we're going to describe here, he was in the pilot. So it couldn't be more complicated than that particular resident in his situation. And he tested the limits of the policy, and the policy worked. And it worked at the time. Stanford was still a 3-year program, and we had, 15 residents per class-ish.
Yep.
So in a 45 resident program, we were able to make this policy work. So just to kind of put it into perspective, we wrote this back before we were 4 years. So when did it not go well?
So the really wonderful answer to this is never, right? Like, we piloted this and it started with the hardest case ever. And then we actually, our second resident in our pilot was a mom who also went into preterm labor and was hospitalized, and it was still fine. Mm-hmm. Again, we had 45 residents in the time. We were super anxious that non-resident parents would resent us. They weren't, they were proud of their program. They actually used it in recruiting to tell other people to come, even though they weren't parents and didn't intend to be. We never got sued.
Oh, there's this lawyer. I've got to tell stories now. There's this lawyer who said that there would be 2 different constituencies, parents and non-parents, and that the non-parents might have a right to legal action against the program because we created a new group. And that was very conservative, and we just worked around it and decided that our residents were probably not going to sue us. And in fact, they took great pride in the fact that there was a policy and in fact didn't sue us. So that was good. True story. So the pilot worked. So this resident return to work policy is actually based off an attending policy that had existed for several years. So just to kind of show the attending policy, then you'll see that it's certainly truncated for the residents, but it is somewhat similar. So for the attendings, a year after the birth of a child or foster care or adoption, there's no nights, there's no call, and you can't work more than 3 shifts in a row unless you ask to work more than 3 shifts in a row. So this is for all of our faculty members. So we changed that up a little bit, and obviously we couldn't guarantee those rules for a full year, but we were able to take the spirit of those rules and convert it into a resident policy. So maybe we can talk about that.
Awesome. All right. So why don't we'll go through our policy and the sections and we'll just hit them one by one.
I see in the chat some questions. Marianne asked, was there pushback from non-parents? There really was not. Like, we expected there to be a lot, and
That actually backs up to whether or not people are looking at transitioning into leave by doing, taking away nights in third trimester. And actually, Stacy actually pointed out first trimester as well, because there's increased pregnancy loss. And then my question was there pushback from non-parents?
got it.
And she
All right,
has
so
100 residents.
that's, yeah, no, we did it in 45.
I will say that in the abstract, there's quite a lot of discussion about pushback and a lot of fear. And then when push came to shove, I guess that was a bad one. It was actually just fine.
Well, and I think the policy supported 2 very complicated pregnancies as well. So I think, you want to take care of your own, right? So I think it tested the policy in a very specific way, and culturally, it had some good normative results in the culture. I would say that. All right, so let's hear about the resident policy.
Okay, let's go to the next slide. Okay, so let's talk about the philosophy and scope of our policy, and it will sound quite familiar to you. It's probably in someone's voice, but it's to respect residents who are parents in a deeply personal manner, thereby promoting well-being, engagement, learning, and retention, which I think is a really lovely way to start that.
And it clues in all the readers that this is a very important policy, beyond just getting your residents some time off. Why are we doing it, and is just as important.
And I think we were really intentional about talking about the return to work and not leave, because that was something that we had control over. And so we state that up front. So there is a parental leave section, and Mike talked about this, but I think it was really important to just collate everything and put it in the same place, because it really does feel like you're reinventing the wheel every single time, right? As the parent, as a chief, as a trainee, as a PD, every time someone comes to you, this is starting from scratch, and we wanted to put everything in the same place. So we put our institution policies, ABEM's policies, California policies. And then I think this is really the meat and what we're proud of, and it will answer some of the questions from the chat. So what we did is we had return to work flexible scheduling for new resident parents. So we said no jeopardy or sick call in the antepartum period for expectant birth mothers for a month, and postpartum 6 weeks for all parents. This no sick call, no jeopardy was based off of the fact that it was really hard to schedule emergency childcare and the unpredictability of scheduling an EM. We all know that the beauty of a flexible schedule comes at the price of predictability, and flexibility sounds really wonderful. And then all of a sudden you have a child and you realize you can't get flexible childcare. So predictability is all of a sudden really, really important in a way that none of us really thought of, I think. So we have no overnight shifts, again, unless requested by the resident. So 4 weeks before due date, which answers that question in the chat, and then 6 weeks after. And again, this is the acknowledgement that these parents are not sleeping anyway. And the idea of having childcare at night is really challenging. And this is a way to support them in doing that. We again say no more than 3 scheduled shifts in a row. We actually found this in our pilot and had a lot of conversations with new parents, and people were finding that those large chunks of being away were really, really challenging, and being able to work in spurts made for better planning and a better transition back.
Yeah, definitely less disruptive for them. Yeah.
Totally. An important part about this is that we acknowledge that our residents have to notify their program. We ask them at 12 weeks, we say before 20, and this was a really hard thing. We discussed this at length. This is hard. This is something deeply personal, and to insist that someone disclose something to you before they're ready, before they may have all the information that they want, is really challenging. But there does have to be some acknowledgement that this scheduling is not easy. And the block schedule affects the day-to-day schedule, and that in order to get the full benefit, the program does need to know.
Yep.
So we have a breastfeeding section of our paper. This outlines the federal policy as just this is what you can have. It then outlines ACGME policy. And then we say that our residents should be expected to leave to pump 30 minutes every 4 hours. And then we outline where there's location of lactation rooms. I actually regret this section a little bit.
Oh yeah, why is that?
Because I think,
Controversy.
yeah, I know, right?
This is great.
Because I realized that to say that you can leave every 4 hours, and we debated this quite a bit. We started at 3 and then it had to become 4. And I think to suggest that what if your baby doesn't eat every 4 hours? Like, why did we say that 30 minutes every 4 hours is what one should expect? What if your baby's eating every 2? What if you have a preemie? What if there's poor weight gain? And you as a mom have to pump every 2 hours in order to get adequate milk to feed your baby, right? Like, everyone's milk production is different. Everyone's magic number is different, how many times they pump versus how many, ounces they get. And I think that wasn't the best thing that we did.
Yeah, I will counterpoint. So that's all very medical and scientific. I will counterpoint that the cultural part of having a certain amount of time dedicated to lactation is a huge cultural change in an emergency department. It's not meant to be let's go into the broom closet for 10 minutes and try to do this as quickly as possible and then go see another patient, and that constant pressure that new moms feel. At least there's dedicated time. Everyone on the team can plan for it as well. Like, 4 hours are going to be up soon and we're going to lose our resident for a little while, and then they can make accommodations. Like, I think there was something to it.
So you think I shouldn't lose any more sleep over my
I don't
guilt
know.
about this?
I mean,
Okay.
in policy 2.0, we can adjust.
All right, sounds good.
All right.
So then we have a childcare section. This is importantly resources, daycares in the area, Stanford benefits. There's an emergency childcare benefit at Stanford, which our trainees often don't even know that they're eligible for. We gave them asynchronous credit and talked about how this can be for pediatrician visits. And we also made it a point to say that children were welcome at all residency education events and otherwise.
Yeah, so if we're going to support the family, it's not just the family in the couple of weeks after the delivery of the child, but it should be supporting resident families all of the time. And I think this is a contentious issue for some folks, whether residents should be bringing their children to conference, for instance, or bringing their children to journal club in an evening event. And our policy says everybody's welcome, as long as, if there's some disruptive children, that you just take them outside until they're able to stop crying or whatever the issue is.
Mike, pre-COVID,
This is all pre-COVID, yeah.
Right, no, I know, pre-COVID, great idea. I did it as well, but now there's limitations by the university and the hospital. You can't necessarily have the kids show up.
Yeah, I mean, I'm sure that's institution specific. I guess I hadn't thought about that for Stanford. I don't know what our policy is regarding that. I mean, we just came back in person, a skinny second ago. So everybody's still trying to figure it out.
And I think also that acknowledges, I think about my first baby who I had in my 4th year of medical school. We say that the leave went so well for me because I didn't have to take it. But then the reality is I still came as an intern with a baby, right?
Yeah.
Like the baby that you have the baby, this leave is brilliant, but then they don't go away. So
They don't.
yeah, this is true. Okay, so then we included this expectant parent checklist, which was really to help our residents work through our policy and to be like, you need to do this now, you need to do this, look here, and to be serve as a guide for them to go through. And so we'll highlight a few things. There were some questions in the chat about health insurance. We say, make sure your obstetric care is covered under your health insurance, right? Because we have 2 hospitals within a hospital and a private group, and just make sure that you actually are covered for your care. This second point is what we talked about. We suggest at 12 weeks gestation, but say no later than 20, and that's something that we discussed for a long time. We say not only do you have to disclose this to your program director, you have to tell your chiefs, right? Because your chiefs are the ones who are making the schedule, and you have to really discuss this with them because there's a lot of moving parts that need to make this happen. I think someone also mentioned in the chat, like, can you get your residents enough hours? And the answer is yes. Our trainees all got the right amount of hours, but this is a real lift from the chiefs with the help of the PD. And so they really need to be in on this conversation. And I think, there was wonderfully a huge sense of pride in our program for this policy, and that people were really willing to dig in and do the hard work that it meant to make this happen. And a lot of that is in the messaging and how this goes. And I think the first time it goes well, then all of a sudden it gets better and better. So this transitions a little bit from your program to GME. There are GME specific things. So we'd say this is the paperwork for GME, inform GME. Make sure you know what the GME policies are. If you're an intern, take a minute because it may actually not apply to you. Then we say, don't forget to put your new baby on your health insurance because that matters too. Get a pediatrician, register for daycare, and know what your resources are.
Yeah, register for daycare the second you become pregnant because there's a huge waiting list.
True story.
We're going to close with just some resources to offer to you all. If you take this PubMed ID, you'll be brought to a pilot test of the Indiana University policy. Their policy differs from ours in a couple of ways. In some areas, their length of a particular benefit is longer than ours. Some of the shift numbers are different, but you'll see a different flavor. And I think the IU policy is a really great one. So check that out. We offer recommended pediatrician lists to our residents. So we just basically crowdsource who's got a great pediatrician. We make these lists for the residents. Same thing for daycare. Emergency childcare resources are available at our institution. So how do you call somebody, and who do you call, and what kind of person's going to show up at your door are all important conversations to have. So we provide resources for that. Obviously, the checklist that we just talked about, any institution or state-specific resources that are available in California has a lot. And then I think the biggest resource is you. So it's you, and it's the culture of your program. It's the tone that you set. I think probably if you're on this call, we're speaking to the converted already, that you believe in the issue. There's a lot of programs out there where there's still very, very few women, and being pregnant is culturally taboo. And that certainly needs to change. And I'm sure that if you ask those program directors, they would say that wasn't the case. But what is the cultural milieu amongst all of the male residents in a program that's like that? And it takes time and it takes effort to change culture. So the biggest resource is you, and certainly how you enact a policy, whether you use something that looks like ours or you think up something that's better for your program. And it's the act of doing it. It's the act of having a policy. And it's the act of testing it out and demonstrating to others. That's what got us normative change that was really positive. So, I suggest, that process as well, being a bit signposty about what you're doing and why you're doing it.
And I think you probably don't take enough credit, but I think the culture of a program where there is a non-mom who is advocating for these things is incredibly powerful and makes a huge difference.
Thanks. So what questions can we answer? I was not following the chat specifically. Anything you'd like to know about our policy or how we define the return to work period?
This isn't a question, but a comment. I think that the idea of having written resources specifically attached to pregnancy and what the rules are and expectations are ahead of time for the person who is pregnant and is huge, right? Just, I was already in attending when I had kid number one, and just figuring out what the rules were was such an enormous amount of effort on my part, and took away from, frankly, what should have been such, and was a joyous event, but it still took away from that. So even the idea of handing this stuff out, like if you have that bullet sheet and handing it out at interviews, isn't crazy.
Absolutely. Other questions or comments? I'd love to hear if any of you have a similar policy and maybe any of the nuanced differences.
We have a somewhat similar policy in terms of types of shifts, but what we realized that there were some people who maybe already had another child or had their childcare set and wanted to still work nights. So we gave them the option of opting out of one type of shift of their choice. Recently, we had a pregnant resident who said, it's really hard for me to get in for the 6 a.m.s. So in the last month prior to her delivery, that was that she continued to work nights and she opted out of the 6 a.m.s because that worked better for her and her family. So that kind of that flexibility there as well.
Yeah, that's great. That's outstanding. It's nice to see you, Kelly.
It's good to see you too. Thank you so much for covering this.
Yeah.
I wonder if people could just, either the two of you or others, speak to sort of the creative ways to achieve the 12 weeks for someone that wants to graduate on time. And so are we calling parenting elective? Are we calling it, letting talks be a reading rotation, which are sort of the tricks that we all do? But I didn't know if someone has like the answer that has always worked, other than just trying to scramble and figure out what we're going to call those basically 4 weeks that always seem to be the rub, to make sure that they graduate on time.
Yeah, I mean, I think we've all tried the research month and the admin month and the QI month and the reading month. And, you know, I've always had a problem with this. I've done it many, many times to help a resident who really wants to get to a certain number of weeks, but we're shortchanging them, right, on their education. Like, electives are you know, a rare commodity, and to take an elective month and just blow it so that you can have an extra amount of time when really I think we should be counseling them to extend training a little bit. You know, I think the hardest group of residents to convince are those that have to go start fellowship on July 1. Most other folks, you can have at least some normal discussion about an extension, and then getting them the time and then the education that they really deserve. And then there's obviously case examples where you don't have to start fellowship on time, and that works well too. But I don't have that perfect answer, Dan. Does anyone else have that creative answer? Yeah, crickets, right? Like, this is not an easy topic. Other questions or comments?
Thank you so much for this talk. I just want to add to your last comment on the return to work flexibility of rotations, that one of the other things that we did was with the telemedicine rotations that came about because of COVID, we allowed some of those residents to do telemedicine rotations upon their return to work. So it wasn't that they were missing out on an elective or some other required rotation, but rather they were just able to be at home physically, which was helpful to some of them, especially if the other parent had to go back to work.
That's brilliant. That's brilliant. Wow, that's awesome. We should do that.
Yeah.
All right.
A good thing from the big C that I call it.
Yeah. Other questions, comments? Well, it was really a pleasure to be able to speak to you today. Thank you, Doctors Marianne and Dan, for having us. And really just any chance that we have to hang out and spend time together, if you can't tell, is positive time. So thank you for giving us that opportunity as well. Take care.
Thank you. Thank you for coming to join us. Really appreciate it.
So much, really awesome. Thank you.